Hey folks, my name is Mo Amir and this is VANCOLOUR, British Columbia's bona fide culture and politics TV talk show. If you watch this show regularly, you know that I am a proponent of safe supply programs, which is when drug users are prescribed pharmaceutical alternatives to illicit street drugs. Street drugs whose unknown potency and composition has killed over 14,000 people in 8 years here in BC. My support for safe supply has been expressed both in my commentary and by guests of this program. I've also expressed support for drug decriminalization. If you watch the show regularly, you also know that I'm more than willing to talk to people with whom I disagree. And tonight, maybe that's what's going to happen, but I'm going to keep an open mind with our featured guest, a weekly columnist for the National Post, best known for his coverage of LGBTQ issues, the war in Ukraine, and his critical lens on safe supply and drug decriminalization. He's also the executive director of the Center for Responsible Drug Policy. He is Adam Zivo. Adam, nice to see you. Thanks so much for being here tonight.
Thanks for having me on the show. It's a pleasure to be here.
So first things first, we know what safe supply is, and I know that you're somewhat critical of safe supply, but can you explain what safe supply diversion is?
Okay, so safe supply diversion essentially is when patients take their taxpayer-funded drugs and instead of consuming them as intended, they predominantly resell them on the street. Now, the main driver behind diversion is that the drugs that we distribute through safer supply is not really fit for the task. So most serious opioid addicts in Vancouver and in Canada more generally are addicted to fentanyl. Mm-hmm. And fentanyl is about 10 to 50 times stronger than hydromorphone, which is the drug that we give out through safer supply.
The brand name is Dilaudid.
It's Dilaudid, yeah. Okay. And hydromorphone Dilaudid, it's comparable in strength / potency to heroin. But if you're on fentanyl, which is 10 to 50 times stronger, and you receive a jar of hydromorphone pills, it's going to do very little for you. So in that situation, the rational thing to do is to sell your free drugs to make money to buy fentanyl, which is your drug of choice, which has the potency to match your tolerance.
Right.
And we tend to forget that, drug addicts are reasonable people. Addiction has hijacked their brain, so they have unreasonable goals, but they know how to rationally pursue those goals.
So I guess where I'm curious is the diversion of pharmaceutical drugs has always occurred. I mean, we could go to the downtown east side and buy Tylenol 3s. We could buy morphine. We could buy methadone, even though methadone is supposed to be consumed under supervision, right? Mm-hmm. We know that hydromorphone, Dilaudid, has also been diverted for decades predating the safe supply programs. So I'm curious, why does this matter now? Why are we talking about diversion in this context?
No one's saying that pharmaceutical diversion is a new thing. Pharmaceutical diversion has been around forever. What is new here is the scale of diversion that is happening. Much in the same way how during the OxyContin crisis, diversion of pharmaceuticals was not new there, but the scale was important in that scandal. So hydromorphone has always been a bit of a rare drug on the black market. Mm-hmm. It used to sell for about, let's say, $20 for an 8 milligram pill. Since safer supply programs have become accessible in Canada, the price of an 8 milligram pill has collapsed to about $1 a pill if you're buying it directly from a safer supply patient, to $3 to $5 a pill if you're getting it from drug dealers who purchase from these patients and then resell in bulk, to $5 to $7 a pill if you're buying it from a street supplier who purchased from those drug dealers. The amount of supply that seems to be getting into communities as a result of this diversion seems unparalleled to anything that we've seen before. And much of that comes down to the immense quantities of hydromorphone that we're giving to safer supply patients. So hydromorphone is used to treat pain. It's used to treat chronic pain and people who are in acute pain after, for example, going through surgery. So if you're in a hospital and you're recovering from surgery, you're going to be given a 2 milligram pill every 4 to 6 hours. So let's say on average, that's about 12 milligrams every day. A safer supply patient in BC will receive 14 8 milligram pills. So that's 112 milligrams every single day indefinitely. If you're in Ontario, you can receive up to 30, which is 240 milligrams. So the average safer supply patient is going to be receiving about 10 to 20 times the amount of hydromorphone of a comparable patient who's in chronic or acute pain. Going back to chronic pain, people are treated with about 12 milligrams or less of hydromorphone if they have arthritis. The only exception for that is people who are in late stage cancer who receive maybe up to about 100 milligrams. So only late-stage cancer patients get a comparable dosage, and that's a relatively small population that is unlikely to divert because they really need that medication.
Where I'm confused is the RCMP said that there is no widespread diversion of safe supply. We've also seen Stats Canada put out a report saying from 2012 to 2022, the rate of substance use disorder has stayed pretty stable and has actually dropped a little bit. So I don't deny, or I think it's reasonable to assume that diversion is happening, but ultimately, what is the impact if it was going to happen, and it has been happening for decades?
Well, I think what's important to note here is that the rate of substance use diagnoses doesn't necessarily match the rate of actual substance abuse, right? Because in order for you to diagnose someone, you have to have that capacity. And we have to be aware of the fact that we're currently going through a healthcare crisis where it's very difficult to get access to a family doctor, let alone to specialized addiction care. So first of all, opioid addiction, like diagnosing that's a lagging indicator. And second of all, our system is not really set up to capture all of the new addiction that we're seeing on the streets today.
So do we have any data to show that there are new people with substance abuse disorders, or that rate is going up?
Well, it's hard to say. When it comes to the data that backs safer supply diversion, I'll give you a few different examples. So in July of last year, the BC Coroner Service released a report that looked at youth drug deaths between 2017 and 2022. And they tried to downplay safer supply diversion by saying that most deaths came from fentanyl and that only 7% of deaths involved hydromorphone. However, safer supply only came out in 2020, so the way that they framed it using that average is misleading. It would be like saying we looked at the data between 1650 and 2024 and saw that on average there were very few automobile deaths, therefore cars are safe. Right. So when you look at the number year by year, you see that 0% of deaths involved hydromorphone for youth in 2017, 0% in 2018, 0% in 2019. Safer supply becomes widely available in 2020. That number goes up to 5.5%. 2021, 9.6%, 2022, 22.2%. So since safer supply became available, all of a sudden you're seeing this very dramatic spike in youth who are dying who have hydromorphone in their system.
But as tragic as those deaths are, hydromorphone was not the only thing found in their system. I mean, it was an intermingling between other substances as well, right? Like opioids and alcohol, when mixed together, can be quite fatal, but it's not necessarily one that's killing you, right?
Of course, and here's a major piece of disinformation that is often shared around the safer supply diversion crisis. People believe that the main argument being made is that hydromorphone is directly killing youth or other, drug users. That is not what we're saying. We're saying that hydromorphone is initiating addictions, which then graduate onto fentanyl, and then the fentanyl then kills people. And so the data that we're seeing within that report is very consistent with that. Most people are dying from fentanyl. A very, very large growing portion of them have hydromorphone in their systems. Now, moving forward, in the autumn of last year, Dr. Sharon Koivu from London, Ontario, published a chart review of her patients in Victoria Hospital in London, Ontario. And so she reviewed 200 patients of hers who had gone through her addiction service between January of 2023 and July of 2023, I believe. And so of those patients, the ones who were not enrolled in the Safer Supply program, 33% of them approximately, reported accessing diverted hydromorphone. And the overwhelming majority of them very explicitly said that they were accessing Safer Supply, right? So we can see that in that city, 1/3 of drug users who are not on Safer Supply are accessing diverted hydromorphone from Safer Supply.
According to what they're reporting, right? But it can still be unclear, can't it? I mean, in BC, less than 5,000 people actually have access to Safe Supply, but there's tens of thousands of people that have access to hydromorphone because they're being prescribed that because of pain, right? So again, how do we know definitively that it's from Safe Supply and not a diverted prescription or a counterfeit?
Well, so I'm going to answer the two different points that you brought up here. So yes, the patient population for Safer Supply is relatively small. So on average, there's about 4,500 patients in BC. The most recent data for the total number of hydromorphone patients comes from 2018 to 2019, of which there are approximately 80,000 patients. So we can estimate that approximately 5% of the hydromorphone patient population are Safer Supply clients. However, as I mentioned earlier, they're receiving a significantly higher dose of hydromorphone compared to everyone else, which is how such a small population has been able to have such a large impact. On top of that, their diversion rate is unparalleled. So it's hard to quantify diversion rates for opioids in general, but the estimate, the upper bound estimate, is about 3%. What I'm consistently hearing from former drug users and former drug dealers is that 80 to 90% of safer supply clients divert, right? So there's just a magnitude of difference here.
Which is, again, anecdotal evidence, right? Like, and I'm not saying you're necessarily wrong. I'm just saying we don't have hard data to prove that. Well,
I mean, like, how else are you supposed to find out about, rates of diversion if not querying the people who are directly involved in this space? Now, there is a lack of evidence, and unfortunately, we do have to rely on anecdotes, and I don't think that's ideal. And I recognize the fact that my research is anecdotal. I'm an investigative journalist. I do the best that I can given my limited resources.
That's fair. Yeah.
If I had a multi-million-dollar research grant, I do things differently.
We have to wrap it up for this segment, but I just want one more yes or no question. To be clear, we cannot attribute hydromorphone dilaudid safe supply to any of the drug deaths here in BC directly. Is that correct?
I think there are a few examples where it has been, but that's gets very complicated.
Okay. Well, when we're back, let's talk about drug decriminalization and what's happening here in BC. Welcome back to This is VANCOLOUR. Last week, the government of British Columbia announced plans to ban drug use in public spaces, which would create new restrictions on BC's drug decriminalization pilot project. To discuss, we're back with one of the most outspoken and arguably influential critics of safe supply and drug decriminalization, a weekly columnist at the National Post. He is Adam Zivo, and this conversation is brought to you by Pacific Sands Beach Resort in Tofino, laid-back luxury, as beachfront as it gets. So, Adam, has decriminalization failed in British Columbia with this recent rollback from BC Premier David Eby?
I think absolutely. I think the public disorder that we've seen is completely unacceptable, and we've seen no real benefits to countervail it. Has there been a significant decrease in overdoses or deaths? Absolutely not. And I think that the failure of decriminalization in BC was in many ways predictable, given that the model of decriminalization that BC pursued was almost uniquely irresponsible and lazy.
Why uniquely?
Well, okay, Oregon also really screwed this up. But let's talk about Portugal, because everyone is obsessed with Portugal and they often misunderstand it, right? So the Portuguese decriminalized drugs in the early 2000s, but they didn't just let people do whatever they wanted. So first of all, in the years leading up to decriminalization, they invested significantly into treatment capacity to ensure that those who wanted treatment could easily access it. Then, when they decriminalized, they essentially created an alternate system of justice where if you were caught openly using drugs or possessing a small quantity, you weren't just let go. You were essentially just sent to a dissuasion commission composed of a social worker, a psychologist, and a lawyer. And that commission could use fines and other punitive measures to coerce you into treatment, right? So they kept you out of the criminal justice system. You weren't, automatically sent to jail. You weren't saddled with a criminal record that could destroy your life. But there were accountability measures that ensured that, you controlled your behavior and that there was a mechanism in place to divert you into the healthcare system.
Right, which is the point of decriminalization, taking it out of the criminal justice system and putting drug use into the healthcare system. But is Portugal a fair comparison? Because they were dealing with an addictions crisis, whereas here in British Columbia, and I guess throughout North America, we're dealing with a toxic drug supply crisis where, people think they're taking something, but they're taking something else and they die instantly. And the drugs are so toxic that even naloxone has started to not be as effective. So is it a fair comparison to say that we should set that up? Because treatment itself, people are prone to chronic relapse. So should you really be at risk to die just because you are going through the treatment process?
Well, I mean, look, like obviously the situations aren't exactly the same, but I don't think that they're as different as people want to make them out to be, right? Like if you want an effective form of decriminalization, you have to have actual mechanisms in place to divert people into healthcare. The BC government just assumed that if you quote unquote destigmatized drug use, then somehow people would be less embarrassed to seek treatment and therefore they would, do so more often. But to my understanding, there's not a lot of strong evidence backing that. And oftentimes people, continue to use drugs because they're locked into addiction, right? They don't quit until there's a really strong reason for them to. And an embarrassment is not something that really dissuades many people.
But if you fear police interaction, then aren't you going to go do those drugs alone or somewhere private, and that increases your risk of dying from a toxic dose, doesn't it?
Well, so that's a different issue, right?
Okay.
So now we're talking about, the benefits of decriminalization, not about whether or not we have mechanisms in place to divert people into healthcare. Sure, some people who use alone, that's a bit more dangerous. I think that you have to balance that against the potential public harms of decriminalization. So if someone uses alone, that's more dangerous. So you want them to use in public, but at what cost, right? And if your city becomes unlivable, and if people are unable to recover because public spaces are no longer drug-free and they're constantly reminded of drug abuse, does that balance out? And I don't think that's really the case.
I think we might have some agreement here where I do think decriminalization was successful in terms of taking it out of the criminal justice system, or at least in terms of interactions with the police. But British Columbia failed to provide the wraparound services to keep people safe or to connect them into the healthcare system. Do you think that's a fair assessment?
I'd say so. I think from my understanding, and correct me if I'm wrong, but decriminalization works when there is a strong focus on recovery. And in the early years of Portugal, we saw that, we saw really great outcomes. We saw decreases in infectious disease rates. We saw decreases in overdoses and deaths. But then starting around 2008, those successes started to disappear. And there's a reason for that, is that you had the financial crisis. And so Portugal suddenly had to make some cuts because it no longer had the money it used to. And of course, investment in recovery-oriented services began to disappear. And so recovery was no longer as available as it used to be. And then on top of that, the state what they started to do is that the government started to outsource some addiction services to nonprofit groups rather than directly provide them. And these nonprofit groups no longer prioritized, recovery. They essentially focused on, quote unquote, destigmatizing drug use and enabling it rather than pushing people into getting better.
Now, really quickly, we have about a minute left. Alberta has moved towards a recovery model, but we've seen their rate of drug deaths also increase, and it doesn't seem to be effective there either in terms of bringing down drug deaths. So it just feels like the key here is to link people into health services. So how do we do that? What is the alternative that we should be pursuing?
Well, so the Alberta model is not perfect. The way that I see it is that it's akin to the Portuguese model in the years leading up to decriminalization. So they've invested a lot into recovery-oriented services, and those services have been online for about 6 months to a year now. But they haven't put in the mechanisms to coerce people into treatment like you saw in Portugal in the early 2000s. So I think, they're looking at involuntary treatments. They'll need to expand drug courts. But from my understanding, they're very reluctant to expand drug courts until they have the capacity to absorb all the people who are being diverted into the healthcare system. You can't push people into healthcare, into recovery, if you don't have beds to hold them.
Right. Adam, thank you so much for your time tonight. I know this is a heavy subject, and I do appreciate you coming here to talk about it with me.
Thanks for having me. I love cross-partisan discourse.
Absolutely. We'll have to do it again. Folks, that was freelance writer and National Post columnist Adam Zivo. Be sure to find his work in the National Post. It is thought-provoking, and I'm personally appreciative of both a diverse diet of local media and an openness to talk about these important issues. Thank you so much to Pacific Sands Beach Resort in Tofino for supporting local conversations, even when the subject matter is not as laid back as their resort. Now, after some business, the big question in BC when it comes to the toxic drug supply crisis is, what now? I'm going to take a moment to ask Premier David Eby that very question up next.